Good evening, everybody. Welcome to the newly diagnosed support group. I'm Neil Burke. I'm the CEO of Prostate Forum. We have a special treat tonight of Dr. Amar Kishan here, who is going to answer a lot of questions about your treatment as far as his specialty. And I am not going to take more of his time and simply introduce Dr. Kishan, and it's all yours.
Thank you very much for the introduction and the invitation to come back. I think I presented here about 2 years ago in June of 2022. Today, I'll be kind of giving an update specifically on MRI-guided radiation, which is similar to the concept I talked about a couple of years ago. We've had a lot of developments here, or just my disclosures for reference. So I think integral to this is the concept of margin. So when treating prostate cancer with external beam radiation, we of course intend to deliver a full dose to the prostate, which is our clinical target, while minimizing dose to the surrounding organs. But there's some complicating uncertainties that we need to take into account. That includes positioning differences. So let's say we're doing 5 doses of radiation on any individual day. There might be slight differences in position of the prostate even as treatment begins. There can be imaging differences. We typically use an MRI to design most precisely our contours or drawing of the prostate, but most radiation planning systems are based on CT, which is a different imaging modality. And most importantly, there's motion. So believe it or not, the prostate does move. It moves about 3 millimeters left, right. 3 millimeters superior, inferior, or top, bottom. 3 millimeters anterior, posterior, or front, back, and about 2 millimeters left, right, in about a 3-minute time frame. Wow. And that's critical when we're talking about treatment with external radiation. So to kind of put a picture to this, let's say, here's the anatomy you're all familiar with. Here's the prostate. The bladder is on top of it. The urethra is running out and through the center, and the rectum is behind. So what we want to treat is the prostate itself. But obviously, we want the treatment to be successful. And because there are these uncertainties, and particularly the fact that the prostate is moving, that's the largest uncertainty, we actually need to treat this blue shaded volume called the planning target volume. And that's a margin around the prostate. And that's actually what we have to intentionally design the radiation to target, that broader volume, because of these margins. And as you can see, that means there is going to be additional exposure of the bladder, rectum, and what you're not seeing on this diagram, maybe some neurovascular tissues that could be responsible for erectile function. And that's why margins are important. This is high-value real estate. Even a millimeter outside the prostate, let alone more expansive margins, are going to mean more normal tissue being targeted. So how do we manage motion? There's a couple of solutions. One is to try to do the treatment very rapidly, so less than 3 minutes of beam on time. And the numbers that I gave you about how much the prostate is moving actually is going to be within a 3-minute interval. That's how much it's moving, but maybe by doing the treatment rapidly, you try to just account for that amount of motion. You can use implanted metallic markers called fiducial markers, and then have serial X-rays taken during the radiation to really triangulate the prostate during treatment. You can try to accomplish the same thing with electromagnetic beacons that are implanted into the prostate. And then what I'm going to talk about and provide some data for is using an MRI-guided platform to directly track the prostate itself. Now, what type of margins are we talking about when we mention these margins? So here's kind of a table of some commonly used or widely kind of accepted margins. And just a reminder, so A here means anterior, which is forward, left, right. Sup-inf means top, down. And then posterior margins are sometimes a little bit different because of desire to limit dose to the rectum. So the PACE-B is a trial, a very important trial out of the UK that made SBRT a standard option there and has been cited globally as well. They use a 5 millimeter margin, except allowing it to be narrowed down to 3 millimeters posteriorly. The NRG-GU005 trial is a North American trial, predominantly US, that was designed to establish that SBRT could be a standard of care here as well. That used 5 millimeter margins, maybe down to 3 millimeters posteriorly. And then at UCLA, we had an extensive SBRT experience dating back to 2010. Initially, the margins may have been a little bit closer to 5 millimeters, but over time, over a decade, this was kind of narrowed down to 4 millimeters in all directions. How is the image guidance and motion management done? Well, we put 3 metal markers that, again, those are the fiducial markers. We place those into the prostate, small outpatient procedure. Those can be tracked with an X-ray or CT. All patients get a CT scan just to check anatomy, and then we do these serial X-rays to try to align to those markers within the prostate. These images can be repeated during the treatment to realign, or we can just do the treatment very rapidly, which is, you might hear these terms like rapid arc or very rapid prostate cancer radiation treatments. Shifting gears a little bit, MRI-guided motion involves no placement of fiducial markers. They could be placed, but they're not necessary. Instead, we're getting an MRI 4 to 8 times per second, which is very rapid, with the radiation beam being paused if the prostate moves outside a preset margin. So we kind of create what's called a gating window around the prostate. And if the target moves outside of that, we pause the beam. Even if only a small percent of it moves outside of that, we can pause the beam. And the fact that we're getting an MRI so frequently, 4 to 8 seconds, every 4 to 8 times per second, that means we can create a movie, like it's called a cine MRI, and it really allows us to have real-time tracking. If the beam has to be paused for more than 2 minutes, 120 seconds, we can do some manual adjustments. But really, because the biggest source of uncertainty and the biggest part of that margin is the motion and motion management, we feel that with this level of real-time tracking, we can really reduce the margin significantly. And here's just an example of this, because sometimes a picture is worth 1,000 words. This is a MRI slice. It's a little bit lower resolution because it's a real-time MRI image from the device. You can see the spinal column, the sacrum. Here's the bladder. Here's the rectum, pubic symphysis, abdominal wall, and here is the prostate and seminal vesicles outlined in red. You can see around that is the gating margin that we have set into the machine. And you can see up here it says target in. So I'll play this movie, and remember, these are MRIs that are being obtained here 4 times per second. Sorry. And so you can see that suddenly there's a motion anteriorly due to rectal gas that causes the prostate to shift forward. Part of the prostate has gone outside this preset window, and it says target out, the beam has turned off. That happened over the span of seconds, right? It's not something, if you're doing X-rays, for instance, once every 2 minutes or even once every 30 seconds, you would miss something like that. That happened very rapidly, and then it resets and target is in. So this is what we're talking about with real-time tracking. Obviously, it's not instantaneous, but 4 times per second is pretty rapid, and it can pick up these small, unpredictable motions. So with that level of precision, we felt comfortable reducing the planning margin from 4 millimeters to 2 millimeters. And again, I understand that those are both very, very small distances, but keep in mind what's right next to the prostate is going to be the bladder, the rectum, and those important neurovascular tissues. And we're really cutting the margins in half, essentially, with this type of approach. So this led to what's called the MIRAGE trial. It's a randomized trial that me and my colleagues ran at UCLA from 2020 to 2021. We hypothesized that by dramatically reducing the margins from 4 to 2 millimeters, we would be able to demonstrate a statistically significant and clinically relevant reduction in toxicity. So the best way to analyze whether a clinical hypothesis is true is to do a randomized trial. And so we designed and launched this trial. It directly compared a toxicity, men getting CT-guided SBRT with 4 millimeter margins, which had been our standard, versus 2 millimeters on this new device. Here's what we treated. We treated the prostate and proximal seminal vesicles. That was the clinical target, expanded by 2 or 4 millimeters to make the planning target. Optional radiation to the pelvic lymph nodes. Positive nodes, if they were detected, could be treated to a higher dose. And the actual tumor within the prostate could also be treated to a higher dose. I'm showing this figure just to give a scope of the trial. Basically, 178 patients came to UCLA during that time frame and agreed to get randomized, meaning there's a coin flip of either getting CT-guided radiation or MRI-guided radiation. These are patients that are oftentimes being seen at the time of initial consult, and so not everyone went on to receive radiation, but the people that declined SBRT in general, were equally distributed between the groups, and we ended up with 154 patients that had 3 months worth of follow-up at least to look at side effects in that acute or short-term time frame. Here's just a peek at kind of the overall patients that were enrolled on the trial. You can see that many of these patients had high-risk prostate cancer. I frequently get asked, can you do SBRT for high-risk prostate cancer? Do these findings apply to people that have high-risk prostate cancer? And yes, they were a fair number proportion-wise of the patients on our trial. And actually, only about 20% had favorable intermediate-risk disease. We did treat the pelvic lymph nodes in a fair number of these patients as well, about 25% in the other group. And spacers were available to be used. They were allowed, and about 45%, 42% CT-guided, 47% MRI-guided got spacers placed. Here's the major results, and again, this is in a short time frame, the first 3 months after therapy. What we saw was a significant reduction in, on the left here, this is GU, genitourinary or bladder toxicity, and on the right is GI, gastrointestinal bowel toxicity. I know the image colors may not be coming through as well, but basically this dark kind of forest green is a grade 2 toxicity, which means moderate toxicity requiring a medication. That's significantly lower in the patients that got MRI-guided radiation versus CT-guided radiation. This is 24.4%. This is 43.4%. So a pretty big difference, and more pronounced for bowel toxicity, 10.5% versus 0% with MRI-guided. So both bowel and bladder toxicity significantly lower. Now, this is physician score toxicity. What that means is, I had to write a medication, or whoever the physician was. Most of these were my patients. I have to write a medication because of their side effect. That's a grade 2 toxicity. Arguably more important, what the patient actually experiences. So you're all probably familiar with some of the questionnaires that people give you. The EPIC questionnaire is asking questions about, say, dribbling, stream, control. So we looked at that as well. Urinary incontinence scores, anything that's less than 0 here, the change in score, it being a negative value, means there's a decrease in that metric, meaning like worse incontinence. So here you can see there is a significant difference between the CT and MRI groups. There's less incontinence in the people that got MRI guided. Now, this isn't real incontinence. It's maybe a little bit of dribbling or something like that, because radiation in general doesn't cause leakage or incontinence, but there is a difference there. The IPSS, or International Prostate Symptom Score, is the symptom burden of, like, say, increased frequency, increased urgency, getting up more at night to urinate. And a positive value, a change that's in the positive direction here, means more symptoms. I know that can get confusing, but basically 19.4% of patients had a big increase in urinary symptoms with CT guided versus only 6.8 with MRI guided. We looked at bowel scores as well. And again, a worse score, a more negative score, means more symptoms. That was significantly different, so less patient-reported bowel symptoms. And if we ask patients, was this clinically significant, that was it notably different, but from baseline, 50% of patients that got the CT guided said yes, and only 25% that got the MRI guided said yes. So in essence, when looking at patient-reported outcomes, benefit in both urinary and bowel outcomes with the MRI guided. The other important point, to be fair, is that at 3 months, these differences did go away, which I think is more a testament to the fact that short-term side effects are, by definition, short-term. They do improve in most patients, and also we're treating these side effects. So that's not entirely unexpected. But the basic premise is that these side effects were caused by increased dose to the surrounding tissues, the bladder, maybe parts of the urethra inferior to the prostate, the rectum. And while short-term toxicity resolves, ultimately what we want to truly avoid is long-term toxicity. Long-term toxicity is also caused by doses to these organs, right? So if there's less clinically significant toxicity, clinical dose delivered to these organs, it stands to reason that that might apply, in the long term as well, with a reduction in long-term toxicity. We'll get back to that in a second. The conclusions here were that aggressive margin reduction with MRI guidance led to a significant reduction in acute physician-scored GU toxicity. That was the primary endpoint of the trial. But we also saw reductions in acute physician-scored GI toxicity, lower percentages of patients treated with MRI guidance, experienced large increases in IPSS score or urinary symptom burden, or clinically meaningful decrements in bowel scores. Our next steps are looking at the long-term outcomes. So that trial finished in 2021. So now we're in beginning of summer of 2024. So we actually have detailed information on the longer term outcomes in terms of side effects through 2 years, actually a little bit longer than 2 years. We're going to be presenting that this fall. I'm not able to tell you what the results are, but I can tell you that we are predominantly still using MRI-guided radiotherapy, which you can read between the lines whether there's a benefit there or not. In terms of the next frontiers for this technology, adaptive radiotherapy, which is something that we hadn't explored yet, is something where you can account for daily anatomical changes. So if on a given day the prostate is in a different position, that you can account for by positional changes. But if the actual anatomy is different, the prostate is swollen, maybe the bladder is smaller, the rectum is fuller, that you need to, if you wanted to account for, you need to actually replan on the table. That's called adaptive therapy. And then dose painting is the idea that maybe with all these increased precision tools, we can increase the dose to the dominant cancer and decrease the dose to the rest of the prostate. So why would adaptive radiotherapy matter? Do we have any data that supports that? Well, there are some early studies that suggest that the prostate swells during SBRT. And the seminal vesicles, which we oftentimes treat, are on top of the prostate. They're more mobile and they can rotate. So we actually looked at this because on the MIRAGE trial, we treated patients with MRI-guided radiation. We got a lot of detailed, easy to read MRI. So we looked for 20 patients consecutively that we treated, what are the changes that we see? And I don't want to get into any of the technical details necessarily, but what this graph is looking at is how much has the prostate volume changed from the planning scan for each of the fractions of radiation that was delivered. And on the y-axis here is how much has it changed. There's a little bit of change at the first fraction, but it's not significant. However, as time passes, you can see there on average, there's an increase in this volume of the prostate of about 15%, which can be substantial. That could mean that maybe part of the periphery of the prostate isn't getting as much dose, or maybe something has changed in that anatomy that would be important to be able to take into account. And here's just an example. Here, is the simulation or radiation planning scan, and here's the last treatment fraction. This patient, for instance, the height of the prostate was about 7.6 centimeters in the beginning. On the last day, 8.2 centimeters. That's a 6 millimeter difference. Remember, in the beginning, we were talking about 4 millimeter, 2 millimeter margins. That's actually a big difference in size. And looking at the anterior posterior dimension as well, it went from 4.9 to 5.2, which isn't as big of a difference, but still, on the grand scheme of things, about 3 millimeters of difference there. So that's what we mean by taking into account these changes in our next kind of investigation of technology. And so that's something called the HEATWAVE trial, which we just opened. We're using adaptive radiotherapy with this MRI-guided device. Patients that have unfavorable intermediate risk prostate cancer are stratified on the basis of their Decipher test to receive a drug called apalutamide, which is a newer drug. But all patients do get adaptive radiotherapy. We think of this as like triple precision. So the Decipher test is telling us biologically how aggressive the cancer is. The drug that we're using is more chemically precise. It's a testosterone receptor blocker as opposed to just shutting down testosterone production. And we're using adaptive radiotherapy. And I'm happy to answer some questions about that at the end. Just very quickly about post-prostatectomy radiotherapy, all the data discussed up to this point pertain to patients who are getting definitive radiotherapy. They didn't get surgery. But for patients receiving radiation to the prostate bed for disease that's recurred after surgery, there may be a role for MRI guidance too. So we've explored this on the setting of clinical trials at UCLA. Our first trial, called the Scimitar trial, was run several years ago, 2018 to 2021. We treated 100 patients. That predated the arrival of this MRI-guided unit. So some of the patients, 69, didn't get MRI-guided radiation, but late towards the end, 31 patients did. We found that toxicity was lower in the patients who got MRI guidance. And here's an example. It was of a Mosin trace in this setting. Here, that's the anterior rectal wall. So there's no prostate for us to track here. And the prostate bed itself is an amorphous structure. Instead, what we're tracking is the anterior rectal wall. And here's the gating window. This is a video that has its own narration. It was created for kind of going over this. So I'll just play it, and you'll hear my voice, but it's coming from the video itself there. So we're able to see while patients being treated. You can see in red the anterior rectal wall, and in yellow the gating margin that we put around it. You can see in this example that the red structure, the anterior rectal wall, is being pushed by a gas bubble forward into the treatment field. This is triggering our beam to turn off, as you can see at the top, target in, target out. This type of very close monitoring is key when we're trying to reduce margins in treating this disease. So if that makes sense, here, what we're tracking is the anterior rectal wall, as opposed to the video I showed you before, where we were tracking the prostate itself, and that's because this is in the post-operative setting. So we're looking at this actively as well. It's called the Excalibur trial. It's been open since July 2021, so it's been open for a while. It's largely using MRI guidance, and that trial is currently open and actively accruing patients. So in summary, planning margins are an important concept when considering any form of radiation, external radiation, but I would strongly say that it's very important with SBRT because of the high dose of radiation we're delivering, and we're only delivering over 5 fractions. MRI guidance allows aggressive margin reduction, thereby leading to reduced side effects by virtue of reduced radiation dose to nearby structures. So I'd like to again thank my patients. I'd like to thank you for the invitation and the rest of my team here. And with that, I'd like to take any questions that may have come up.
Thank you, Dr. Kishan. I'd like to start with Dr. Metzger.
Dr. Cash, thank you so much for giving us this presentation. It just seems so clear when you talk about things that we have questions about. I have just one question about dose painting. Wouldn't it be easier to use PSMA scan to do dose painting?
Yeah, we on that trial, for instance, we'd be using both an MRI and PSMA PET. So those are things that go into designing the treatment, but when you're delivering the radiation, you're using the external anatomy and the anatomy of the prostate. But you're right, a PSMA PET can help delineate the target within the prostate. However, MRI actually does have the best spatial resolution. So for looking at the prostate itself, as opposed to say a lymph node outside the prostate, an MRI would be superior. So we do allow the use of both.
And has there been any change in your direction of metastasis-directed therapy with SBRT and guidance?
Yeah, no, that's a great question. So we aren't using the MRI guidance as much for metastasis-directed therapy, because I think the key, the benefit of MRI guidance, in my opinion, is when you have either some structure that's highly variable in its anatomy, or it's moving a lot, and fixed lymph nodes don't necessarily do that, or bone metastases don't do that. Where I have used MRI-guided radiotherapy in that context is if someone has had prior radiation, for instance, and then they have a lymph node that comes up next to the bowel or next to the rectum, it may be beneficial there to do that adaptive radiotherapy, where you change the treatment based on the anatomy of the day to further protect the rectum. That doesn't require MRI guidance. There are other machines. You may have heard of things called like the Ethos machine, for instance. These are CT-guided adaptive treatment platforms. Those exist as well, but that's where it comes into metastasis-directed therapy.
Yeah. Well, once again, thank you very much. It's just really a great talk.
Thank you.
Right ahead.
Yeah, I'm back on. Okay, Dr. Kishan, a question. If you had prostate surgery years ago, and you may be at a point where you be painting the prostate bed with radiation, okay, non-specific points, okay, do I understand that basically using this technique or MRI-guided, you can prevent radiation from hitting the rectum, the rectal wall?
You can't prevent radiation from hitting the rectal wall, but you can minimize the radiation to the rectal wall. So that there, even with that technology, which is really kind of pausing the beam if the rectal wall moves, there's still going to be some radiation going to the rectal wall. But the idea would be that it's limited. It's limited significantly compared to what we were able to achieve previously.
Okay, so basically, in a scenario where you're painting the prostate bed, this is post-surgery and recurrence, that there's no avoiding part of that, there's no avoiding the rectal wall.
Yeah, I mean, so the high dose, we tried to have the high dose limited to the rectal wall, but just because the physics of the way the radiation dose kind of falls off, I cannot say that we can avoid the rectal wall. There'll be some exposure to the rectal wall.
Okay.
Okay, go ahead, Ross.
Just long-term effects. I think you mentioned it's going to be published later in the year, the results for the long-term effects.
Mm-hmm. But two-year effects, which is not super long-term, but it's a newer technology. So that's, but it is a long-term update. Yes.
So A, does that mean you're going to come back and give a presentation on that when that occurs? Or B, let us know the results and where it's published at so we can review it?
Sure. I mean, if I'm invited back after this, then sure, I'm happy to. I saw someone say, "Can SBRT radiation affect your voice?" No, it shouldn't. I mean, we're talking about aiming at the prostate or prostate bed, so that wouldn't. I mean, if someone was treating in the neck for, say, someone had like a lymph node very close to the larynx in the throat and they had metastatic prostate cancer, there could be some hoarseness as a potential side effect, but not for radiation in the prostate. No.
But you have to get back, and we very, very much appreciate your time and look forward to your return.
All right. Thank you very much for the opportunity. I'll see you in the future. You take care.
Thank you.
Thank you.
Take care.
Thank you.
A quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends.